Good morning, good afternoon, and good evening to our attendees here and online. The second seminar in October actually marks the second hybrid seminar that we are going to have. And we are very glad to have Professor Donovan here for a talk with a very captivating title, From Brave to Momentum, a 20-plus-year journey. But before we start, I would like to ask Professor Caroline, the Director of Research Center for, I messed it up, research in health communication, sorry, to kindly introduce our invited speaker, and we will be back after the talk for the Q&A. Thank you very much.
Thank you, Azar. And yes, it does give me very great pleasure to introduce my friend and colleague, Professor Caroline Donovan, who's going to be talking to us. In particular, I was very interested to have Caroline come to address the department and the center, the International Research Center I've actually forgotten the proper name of it myself. But in particular, I wanted Caroline to kind of share her story, as you're about to see, of taking a really viable and strong research program in clinical psychology primarily, but increasingly with a broader spread of sorry, we're just getting an echo here. Better switch. Someone's got their mic on. Mute them. Yeah. Could people mute their microphones, please, who are viewing? That one there. Oh, okay. And well due to follow. So in just a minute, when we've sorted out the sound issue, I will pass you over to Caroline Donovan.
Thanks, Stefano, for your very warm welcome, and I feel very privileged to be here to talk to you about my program of research and that of my colleagues. So I'm going to talk to you today about a program that we've developed in clinical psychology. It's a cognitive behavioural therapy program. So it looks at cognitions and behaviour, and it's a paediatric program that was primarily originally aimed at anxiety disorders in children. And we have used that program and we've digitized it. So it's now an online program. It was developed as both, and as I'll tell you about in a minute, but it's now an online program that's completely, all of the content is now online with no therapist assistance. So I'm going to tell you about how we got to that point and what we're doing next. So today I'm going to talk to you about what BRAVE is, the long road. We've been doing this for nearly 25 years now, the evidence base that we have for BRAVE, the problems that we're facing currently, because that's changed a little bit recently, and Momentum, which is our latest version. It's a new program that we'll be launching soon, the vision of that, the platform around it, and where we're up to date. Okay, so let's just talk a little bit about why we're here in the first place and why we started doing this in the first place. In Australia, we've got a one-year prevalence rate of mental health issues in children of around 14%. So in real terms, that's 569,000 children each year have a mental disorder of some description. of those, 70% have anxiety and or depression. So they're by far the most common disorders. But only around 50% receive help of any type. And that could just be a GP visit. So it might not be real help, but they seek help of some sort. Only 25% see a person who's trained in mental health service provision. But only 11 to 12% receive enough treatment that would actually make a difference. So that's not really very good numbers. Okay. And the barrier, so why is that? We've got lots of psychologists and we've got really good treatments. So why aren't those children receiving the help? And there's lots of reasons. Stigma is one. That's reducing in Australia. We've got platforms such as Beyond Blue, who are doing a lot of, I guess, mental health service and mental health generally. They've made it, they've advertised it, they've talked about it. It's not so much a stigmatized thing anymore, but it's still there, and particularly amongst adolescents who don't like to be different to their peers. Cost, it's still a big cost in Australia to see a psychologist. Wait lists during COVID were well over 12 months to see a psychologist. Geography, I'm going to give you a geography lesson in a moment about Australia and why that's such a problem. And busy family schedules, multiple children, they've got to get kids to school, to sport, to music. And it's really difficult then if you're also working to try to get children to mental health appointments as well. So lots of different reasons. And online programs circumvent a lot of those barriers to treatment provision. And they work. So I'm going to talk to you about ours and how it works. But first, you're going to get a geography lesson about Australia. So some of you are from Australia. Some of you have been there, I presume, and many of you have probably heard about it. So I live in Queensland. Steph also lived in Queensland, and Francis, in Brisbane. But Australia has got numerous states. Queensland itself is known for many things, like our beautiful Gold Coast and our Barrier Reef, and the Queensland Maroons, our mighty football team, which Stefano doesn't care about because he uses it. He's interested in a different code of football. But for us who follow the rugby league, Queensland won this year. So we're all very proud of that. It's a land of contrasts, Australia. So this was one of the slogans for Queensland. It's beautiful one day, perfect the next, unless we're on fire in a cyclone or underwater. So we do have a lot of tropical and cyclones and natural disasters. We've got some of the most beautiful animals in the world, the little koalas and the kangaroos and the platypus. And we've got many that will kill you as well. A land of contrast. We've got beautiful cities, Sydney in the middle there, Brisbane on the left, Melbourne on the right. But we have an enormous amount of rural and remote areas where there is nothing for kilometres and kilometres, no services. So people in rural and remote areas could be 400 kilometres away from anything, another person even. And that is what it looks like. There is nothing there. Australia is also very big. So we can fit Europe, the whole of Europe in Australia. And that blue part is the most remote parts. Only the red bits, and if you have to look really hard to find the red bits, there are metropolitan areas. The sort of yellowy colour are what we would call regional areas, and everything else is rural and remote. So huge amounts of Australia are rural and remote, but 28% of our population live in rural and remote areas. So a lot of people do not have the services that metropolitan areas would have, even in terms of doctors and food and petrol, let alone mental health provision. And so that was really the thing that spurred us on. We knew that there were a lot of children in rural and remote areas who had mental health problems who were not getting any assistance of any kind. So we developed Brave. So I'm not the only person on Brave. I've got a beautiful team, Professor Sue Spence and Sonia March, and my very good colleagues and friends, and we've been working together on this for about 25 years now. But there's been a whole lot of people. We've had numerous grants, we've had numerous postdocs and PhD students and research assistants helping us. So there's been lots of people over the 25 years who have contributed to this research, and I'd like to acknowledge all of them. Couldn't have done it without them, that's for sure. So what is Brave? So Brave is a suite of internet programs, cognitive behavioural treatment programs, targeting anxiety disorders in children and adolescents. So we've got 3 different versions of Brave. We've got a preschool version, we've got a primary school age version, and we've got a high school age version as well. Within each version, there are child sessions and there are parent sessions. For the preschool one, there's just parent sessions because obviously preschool kids can't read. And it's a generic anxiety program. So we don't have one for specific phobia, one for social anxiety and so on. It's a generic anxiety program that's designed to treat all of the different anxiety disorders. So I'm going to tell you the story of how it all came about. So of course, it was Sue's idea to start with, Professor Sue Spence. She was my PhD supervisor at what feels like a million years ago. And she's a very brilliant woman who has a lot of vision. And we're going back 25 years. It's hard to imagine what it was like because we have lots of online things now, but 25 years ago we did not, and we were not popular for coming up with this, what we thought was quite a brilliant idea. Not everybody thought that. They thought we were going to steal the jobs of therapists, that how could you possibly have a working alliance online? And we were very unpopular at the beginning. But nevertheless, Sue decided that we've got to use this World Wide Web to our advantage. And she decided that one of the things that we would try to apply for a grant for would be to look at comparing face-to-face version of Brave with a hybrid program. So every second session was online and every other session was face-to-face. And what we found was that there was no difference between those two conditions in terms of their reduction in anxiety. So that gave us hope. Then Sonia went on to do her PhD on the primary school version of Brave. And in that one, we had a full internet version of Brave versus a waitlist control. And we found that at 6 months follow-up, 75% remission rates, which were up there with face-to-face therapy in comparison, for those of you who know a bit about that. Then we had the teen version, and that became part of my postdoctoral fellowship at the University of Queensland. So we looked at a full internet version of Brave versus individual therapy, face-to-face therapy of Brave versus a waitlist control. And we found no difference between the individual therapy and the online version. Okay. And at 12-month follow-up, 78% of the online and about 80% of the face-to-face had remitted. So it was really, they were very, very similar rates of remission. So we're very impressed. And the teenagers loved it, particularly. They were very happy with the online version. And then we did Baby Brave. So this is the preschool version. Just a parent only. It was a very small pilot trial, but again, we had 70% remission rate. So very high remission rates and up there with what we would see in face-to-face therapy as well. We then went on to, so in more generic programs like Brave, what we found and what they found in face-to-face therapy is that the socially anxious kids don't do as well generally in these more generic programs compared to those with other anxiety disorders. And so what we thought was we would develop a social anxiety specific version of Brave and test it against our generic version. It was an enormous amount of work and we found no significant difference between the two. We were really hoping the social anxiety version would be better, but in fact, we still had really strong effects with both. Okay. They were also very severe. So the children who decided, or the teenagers, they were teens and children in this study, who wanted to take part in this study were really severe cases of anxiety. Most of them weren't going to school. Most of them weren't leaving the house. They were the most severe group of kids that we have had in any trial. So they still improved, which we thought was really good because oftentimes online programs are sort of advertised as being only for mild or moderate severity levels. But we found that with these severe kids, they were still showing really good remission and reductions in their anxiety symptoms. We then went on to try it with children with Asperger's, which we don't call it Asperger's anymore, but we did when we did this trial. And because, you know, all of our other trials, Brave, we excluded the ASD population and just focused on neurotypical kids. So we did find it was still significant. We had a significant difference compared to the waitlist, but the remission rates were a bit lower. We think that really it needs tweaking for an ASD population, and we need to put in some social stories and so on that we would use with an ASD population. So all of those studies, there were 8, we've done 8 randomized controlled trials so far, have been with what we call a therapist-assisted version of Brave. And when we talk about therapist assistance, it's very minimal. So the kids do all of the content online, but they type in answers and so on. And a therapist will look at those answers and then just give a paragraph via an email of feedback and encouragement. There was also one phone call during the course of the program to help them develop their exposure hierarchy, which is an important component where you sort of the children are exposed to their fears very gradually in order to overcome them. So to develop that hierarchy, it was really important that we had a phone call with the therapist at that time. So all of the RCTs were done with this therapist-assisted version. We had great results, but the problem was that only the people who were in our clinical trials ever got a chance to use it. How could they? There was no way that they could access Brave in any other form. And so in 2013, and then again in 2018, we were funded by Beyond Blue to develop a completely self-help version of Brave, because that was the only way that we can disseminate it in our country, really, at this point. Internet therapy is not funded by Medicare yet in this type of form. And so national dissemination was only possible in a completely self-help format. So we had to do lots of changes to the landing pages, and most importantly to that development of the anxiety hierarchy, because we needed a lot more, they needed a lot more help with that than currently was in Brave. So we had a tool that helped with that. So enormous response, huge impact. So to date, we've had 77,462 registrations for Brave, and they went up 400% in the first week in COVID. And overall, over the 2 years, it sort of did come down a bit, but 30% increase over that COVID overall, but 400%. They were so anxious. It caused such anxiety amongst our young people in Australia and obviously elsewhere. But it showed the huge need for evidence-based therapy that these kids weren't getting. So we sort of felt like if we died on that day, once this had all happened, we would have been happy. Our program was out there. It was available to all Australians free of charge. And we thought that was pretty good. But of course, we don't stop there. We have to keep going. So we've done some stepped care studies that I'm not going to bore you with the details here. But essentially, this isn't stepped care in what you might have sort of read about elsewhere. It's internet-based stepped care. So if we think about gold standard internet therapy as being our therapist-assisted Brave, we then compared it to a stepped care where they all started in self-help Brave, and if they didn't respond, they were either allocated to the therapist assisted, and if they did respond, they just kept going with stepped care. And that's because if we use Brave as a therapist assisted version, we still need a therapist of some sort. Even though it's a lot less than face-to-face therapy, a therapist is still needed, and in our country, that's not going to be something that can happen at the moment. So we did one with therapist assisted Brave via the email, and one via video conferencing. They're being written up at the moment, but they were non-inferiority trials. And what we found was there was no significant difference between giving them therapist assisted all the way through or this stepped care model, which is really good in terms of service provision going forward. For the video conferencing one, which hasn't been written up yet, so I'm giving you a bit of a sneak preview here. The video conferencing was superior to the stepped care approach. And in fact, we had 87% remission rates, which was the highest we've ever had for Brave. So our video conferencing version of Brave appears to be our best yet. So that's exciting. So here's all the evidence. We've got lots of evidence that Brave works, and there's been lots of other studies looking at predictors of outcome and so on, which I'm not going to bore you with. But I think it's important there's a lot of online programs around, and it's really important that we're looking at evidence-based online programs for our young people to make sure that they're getting the best possible care. So I thought you might be interested in having a look at what Brave actually looks like, because you guys can't access it here. It's only available to Australians, unfortunately. So here you can see that the Young Child program has 4 sessions. They're all parent-focused sessions. The Child program has 10 sessions for the children and 6 for the parents. And the Adolescent program has 10 adolescent sessions and 5 parent sessions. That's our landing page. So if you went on and had a look, you can see there's the 3 that you can choose from. Anyone can go on. It's free. You don't have to do anything special to access it. When you click on it, that's the page that you'll get to. And you can see here the different sessions that they click on. So they have to do one session before the next session becomes available. They can't just pick and choose sessions. They're sequential, and that's important because they skill build on each other. Okay. That's what they look like. You can see they look quite different to each other depending on the age group. The structure of the sessions really does follow what we would do in a face-to-face therapy format, where we review the homework from the previous session. We try to remind them what's happened from the last session so they remember. We introduce a new concept. We provide an example where we encourage them to then work through that new concept on their own. And then we review the strategies we've taught and provide new homework. So it's very much in line with what we would do in a face-to-face therapy format. And just to give you an idea, this is the young child one. This was developed much later than the other two Brave programs. So it's got quite different graphics in it. And this is the child program. So you can see that it's very interesting. So it's not just text on a page. We tried to really make it like what we would do in therapy with kids. We're very interactive. We're drawing with them and they're filling things in and they're doing stuff. We don't just sit and chat to children. So we tried to emulate that in an online format, which was fun actually to develop it. So they do little things and there's sounds. None of those pages are static. We've got our Brave Buddy there, as you can see, our mascot. We use a lot of stories. So Worried Wes and Brave Brenda is an example where Worried, they're two kids who are trying out for the school band, and Worried Wes is actually the better musician, but he's too scared to go and do the audition. But Brave Brenda goes and does it. And so it's trying to teach children that by not pushing themselves a little bit, that they can miss out. So it's trying to explain to them the avoidance type cycle that can happen in anxiety. So we use stories a lot, and it really gets the children really remember those stories, and they'll say things like, oh, it's like Worried Wes. Yeah, it works. And here we've got Charlie and Squeak. So Charlie is a little boy and he loses his guinea pig Squeak, and he goes through the 6 steps of problem solving to go and find Squeak. So this is an example where we externalize it to something different first, teach the skill, and then apply it to their own anxiety example. So they get it first without resistance, and then they're happier to take it on. The teen program, you can see the graphics are similar, but more age appropriate. We're very pleased that 25 years ago we went with a cartoon format because it really has actually stood the test of time. It's still okay today. And you can see here, so we've used different stories and different graphics, but it's along the same idea. And BRAVE's an acronym for the strategies that we teach. So B stands for body signs, so recognizing the physiological signs of anxiety. R stands for relax. A stands for activating helpful thoughts, which is the cognitive part, working with thoughts. V looks at our BRAVE ladder, exposure hierarchy and problem solving, and E looks at rewards and reinforcement. There's lots of videos and animations. We've got audio tracks, there's examples, there's printable activities that they can do, there's text boxes, there's bits to read. We've got a resource center too, so they don't have to keep going back through their sessions to find bits. They can just go to the resource center and look for those particular resources that they might need. We've got a relaxation room where they can do all of their audio tracks without having to go back through the program. We've got a worry chart. So each session they do the CAS-8, which is just an 8-item anxiety measure, and that gets monitored so they can sort of see how they're going over time. And they really like that, actually. They like it when they go from the red zone into the green zone. It makes them very happy. And we've got a BRAVE ladder interactive tool, which I'll actually talk to you about more with momentum. But the end of the story isn't necessarily a happy one with BRAVE. So BRAVE's old, the tech's old, and while it looks okay, the back end of it, we've had multiple patches. We've had to take it. It was in Flash to start with, which most of you probably never even heard of. It's been moved from platform to platform, and it's really hard to get funding for redevelopment, and it's really expensive because they're big programs. The intellectual property sits with the University of Queensland, where none of us are anymore. So they own BRAVE. And while they've been really helpful and happy for us to continue our research and to nationally disseminate, they're now looking at commercializing BRAVE, which will mean that the free version will be turned off at some point, which will be a very sad day because that's why we did it. So it'll be a sad day, but there's a happy story as well, because we knew that was going to happen. So we've done momentum. We've got a new one. Might stop here just if anyone's got any questions about BRAVE, first of all. And I know not all of you are psychologists, so I hope that wasn't too difficult for you to get all of the cognitive behavioral terms there. But has anybody got any questions, anything on the online chat? Oh, I couldn't. Please go with the question. She has addressed it. There was a question about okay.
So, sorry. Thank you very much for this. It was very interesting. Actually, I wish it was available for me because I think we would all love to work with that and learn how to go over that. You just mentioned something. Of course, I'm not a psychologist, so I don't have expertise in that area.
Yeah.
About the COVID period and
Yes.
the fact that Brave focused on generic anxiety.
Yes.
So during the COVID, did you feel the need to make any changes to the platform or any additions? Because it seems, I'm not sure, but it seems that the anxiety that COVID brought, a pandemic brought with itself, might be a little bit different from generic anxiety. Is it or it is not?
I probably didn't explain what I meant by generic very well. So let me explain that.
Or I don't know what is
no,
generic.
No, it's a really, really good point. And it's an excellent point. And so, and again, I'm expecting everybody to understand what that meant. So I apologize for that. When I said generic, it's targeting all of the anxiety disorders. So specific anxiety disorder, generalized anxiety disorder, social anxiety disorder, and specific phobia. So all of those, which are the four main anxiety disorders, are covered in the program, in one program. So when I said generic, it just is one that covers all of those, but there's specific examples of each of those. So what we saw in COVID coming out more specifically was specific phobias around contracting illness or generalized anxiety around what's going to happen. They're very worried. So generalized anxiety disorder is an anxiety disorder of worry, where there's lots of different worries about lots of different things. And that's the biggest one we saw in COVID. So they're the kids who worry about pandemics, about death, about finances, about everything. They worry about lots of different things, which they usually don't need to worry about. But the pandemic really sparked a lot of that. And we see it in Australia. We have a lot of bushfires and cyclones and things like that. And whenever there's a natural disaster, we also get a big spike in the use of Brave because of the generally anxious children. So when I said generic, it would still cover it very well. There was obviously no COVID specific examples, but there were examples of getting sick and illness, and which would easily be sort of generalized to that. Yeah. Does that help? I hope so.
And they were
That's an excellent question.
Thank you. And they were very lucky to have that.
They were we felt like it was a very useful tool, particularly at that time. Yeah. Brave's also been used in New Zealand when the Christchurch earthquake disaster happened. It was used for 3 years after that because of the aftershocks. So we exported it to New Zealand and they used it for free as well. They are our cousins after all. So, yeah. I can talk about stepped care at the, I brushed over that a bit, but yeah. Yes, I could go into more detail about that, but I didn't want to bore people. Yeah. Okay. Sounds good. Okay. So momentum, this is our next step. Sonia and I had talked a lot about the issue of comorbidity. So comorbidity means having more than one disorder. So first of all, lots of kids have more than one anxiety disorder, but also kids with anxiety often will have depression and other disorders. And so we were really interested in that because we know when there's a comorbid disorder, the treatment, whether it's face-to-face or online, isn't as useful. Okay. So there's also the concept of tailoring. When they do have these comorbid disorders, usually we don't tailor it. With online programs, they just get the program, whatever that is, for anxiety, for depression, for substance use, whatever the online program might be. And so we had this idea, wouldn't it be great if we had a one-stop shop where the kids could be assessed, they could get feedback on what their issues are, and then they would get a program that's completely tailored to whatever problem that they had. So we thought that was a bit pie in the sky until MRFF put out a call. So the Australian government put out a call for research projects. And this was the first time an MRFF program of research came up, actually. And this was their words: bold and transformative research to support 1 million people with mental health issues access new and innovative approaches to prevention, diagnosis, treatment, and recovery. And we thought, oh, that sounds like something we might be able to do. So that's exactly the argument that we use, what I talked to you about before. And we thought, well, we can access 1 million more minds if we target the most common. So we're talking national here. We're talking much public health situation, okay? If we could target the most common disorders of childhood, we could get more kids. And if we use the most accessible, cost-effective and evidence-based care, we could also target more kids. So that was targeting anxiety and depression and their associated disorders, and using e-mental health or digital mental health like Brave, okay? So we know that comorbidity is high. 70% of youth who have a mental illness suffer with anxiety or depression. They don't usually improve unless we help them. And we know that anxiety and depression, if they've got them as kids, they are much more likely to have them as adults. And not only that, but if they've got anxiety and depression as kids or teens, they're more likely to develop a whole range of things, including problems academically, socially, psychologically, even physically. Okay, so there's a lot of problems, not just whilst they've got anxiety and depression concurrently, but also later. And so our idea was, if we could target anxiety and depression when they were young, we would not only be helping them right now, but we would also be preventing the emergence of other disorders later on. So in terms of e-mental health, 97% of Australians have access to the internet. It's cost effective. There's no stigma. We know it works for anxiety with our program, but we've also got other investigators on this grant who look at substance use and also depression with Mood Gym and so on. So we know that the things that we were targeting, we have experts in Australia in e-mental health who can help. So comorbidity, 50% of depressed youth have an anxiety disorder, and 1/3 of anxious or depressed youth have some other additional disorder as well. Comorbidity is more the norm. It's not the exception. Okay, so they've usually got more than one. It's very rare for the clinicians amongst us. I know Francis is here, will tell you that very rarely do they just have one issue. And it negatively impacts the treatment that we provide. And so the solution is to directly target that comorbidity, which has not happened previously. So we decided that using this collective knowledge, we could develop a whole platform where kids and families could come in, answer questions online, do an assessment, get feedback on what their issues are, and then be given a program that would target their actual diagnostic profile. So that was a big ask, but that's what we decided to do. And I'll tell you a bit about how long that's taken us, a bit longer than we thought. This is the chief investigators on Momentum. So it's a big team of experts from Australia. And we've also got partners, so community partners. So Kim's is our Child and Youth Mental Health Service. We've got the Queensland Department of Education, Aftercare, which is a private psychological entity. And we've got the PHN. So those two bottom ones are community-based or government-based mental health services in the western suburbs. So this is what happens. They go in, they get assessed. We get data on their anxiety, depression, sleep, substance use, diet, and exercise. So we're taking a very holistic view of their mental health here. They get feedback based on that assessment, and then they get a tailored program. So obviously this is part of service provision, but it's also a research project. So they're running simultaneously. There'll be national dissemination of this platform at the same time as numerous RCTs and other trials that are going on. So just to give you an idea, I know you're all researchers, so you're probably more interested in the research part. So there's 3 streams of research and 8 projects. And it's for youth aged 7 to 17 at present, but I am pushing to get the younger ones in because they're the ones that I particularly like working with. So this is our ridiculous research stream. We've got 2 on the detection and assessment part. We've got 4 projects in the intervention phase, and we've got 2 on the implementation effectiveness phase. So it's there's a lot of projects going on at the same time here. So what does it look like? Now, it hasn't launched yet, so spoiler alert, we haven't started. It's launching now. We've got a launch date for the 1st of November, finally. It's going to be exciting. But this gives you an idea of the number of programs. So when I remember Brave just had one program, anxiety. So it was like the little one at the top there, anxiety. This has got all of these. Okay. So if they've just got anxiety, they get the anxiety program. If they've just got depression, they get the depression program. If they've got comorbid anxiety and depression, they'll get one of two different ones. Okay. Depending on which is what we call the primary disorder, the one that's the worst, if you like, the one they're having the most trouble with. 2 different comorbid ones. Then they've got an anxiety and sleep, a depression and sleep, and comorbid and sleep. So they can get those ones. If they've also got substance use problems or lifestyle issues, they also get those, but they're after those main programs. They pop up at the end of those whatever integrated program they go into. These other modules will then pop up at the end rather than integrating them, but they're there. So we have ones for substance use, and depending on how many substances they're having problems with, they get between 1 and 5 sessions. So we've got substance use modules for nicotine, alcohol, cannabis, MDMA, and meth, and lifestyle ones looking at diet, exercise, and screen use. So this is all the combinations they could have. I won't bore you with it, but you can see there's a lot, which means that we've had to develop all of those programs. And if we make a change in one anxiety thing, we have to make them across the board. It's been a very big job, and it's a big study. So I'm hoping that I can show you a couple of videos to give you an idea of what the actual program looks like.
Welcome to Momentum. Many young people in Australia suffer from emotional problems. This can include problems with feeling scared and worried, with sadness, difficulty sleeping, and even problems with diet, exercise, and screen time. Finding help can be hard. Momentum is a website that aims to make things easier for young people and their families. It provides free mental health assessment and treatment that is easy to use and all in one place. After you and your grown-up register with Momentum, you will each have separate accounts. Your grown-up will also be asked to complete the Momentum checkup. The checkup includes lots of questions.
This is the assessment phase.
What
Yeah.
problems you are having and what sessions would best help you. Our sessions are designed so that you can do them on your own or with a grown-up, whatever works for you. Each session has been designed by experts so that you can learn about what's going on for you and how to cope. Sessions are fun, interactive, and include interesting pictures and videos. Momentum includes lots of other great features too. Customize your profile by choosing a profile picture, using nicknames, and editing website themes. Build a Momentum toolkit that helps you keep track of the different skills you learn over each session. Track your feelings each week so that you can see your progress over time. Receive automated reminders and helpful information straight to your inbox.
There's a messaging system as well.
Access resources that help you practice and use your new skills like videos, tip sheets, home practice tasks, and online tools. Find extra information on important issues like friendship and coping, as well as how to ask someone for help. Earn rewards like stickers, badges, and even fish for your fish tank for completing sessions and practicing tasks. If you're under the age of 12, you'll need a grown-up's permission to register with Momentum. To start, grab your grown-up and click the register button at the bottom of the page.
So that's our little introductory video that they get on the homepage, so that it gives them a bit of an idea of what they're in for. Okay.
Welcome to Momentum. Many young people in Australia suffer from emotional problems.
The same one, wait a minute.
This can include problems.
I can go on to the next one. This is a bit more about the feedback.
My name is Dr. Laura Ullman. I am a clinical psychologist and research fellow and one of the many creators of the Momentum program. You have just completed the registration process, and before you can start using Momentum, you will need to complete the Momentum checkup. The Momentum Checkup is how we develop your personalised treatment program. Momentum differs from other self-help programs because it can give each young person a tailored treatment that is suited to them and their individual needs. Whether you have one problem or more than one problem, Momentum uses clinically validated assessment tools to work out the areas you need help, rank these issues in order of their severity, and then recommend a tailored treatment program that is designed to help. The checkup involves lots of questions about your feelings, thoughts and behaviours. You will need about 20 minutes to complete the checkup, and you will not be able to save your answers and come back, so you will need to complete it all in one go. Completing the checkup will provide you with a personalised report, which shows you the areas you need help and the severity of your problem. You can keep this for yourself or share it with a trusted adult or health professional. And a personalised treatment program that ensures you are getting the right help for you. Once you are finished, you will immediately be able to view your checkup results and start your Momentum program. You can view your results at any time via your homepage. To get started, simply click the orange Next button and start answering the questions.
Okay, so I've also got a video on more of the exposure hierarchy tool, but given we don't have too many clinicians here, I might not show that one. It probably won't mean as much to you. It might be more useful to have question time where I can answer any questions that you might have that are specific to what I've talked about. So I might leave it at that for now. And so thank you very much for listening.